All right, good morning, everybody. Thank you so much for joining. My name is Rachel Krug. I'm the CEO of Virtual Field, and I have Dr. Leslie Odell on the webinar with me. We're going to be speaking about maximizing visual field utilization for the medical optometrist. Dr. Odell, would you mind giving a brief intro of yourself?
Absolutely. Well, first of all, thanks for the opportunity to talk about visual field testing. I am a veteran medical practicing optometrist in practice for about 20 years in multiple settings. And I can say that my life would never be the same if I didn't have access to visual field testing. So I'm grateful for the recent modifications and adaptations in technology that are not only helping me, the provider, but my patients as well.
Amazing. Thank you so much for that. And just to set the stage a bit, there is growing demand for eye care services and a shortage of ophthalmologists and technicians. And so medical optometrists play a pivotal role in filling this void and providing comprehensive care. We're going to talk about a variety of topics related to visual field testing today, including the Esterman exam, screening and managing glaucoma, diabetes and macular degeneration. We certainly have an ambitious agenda here. We're going to keep time to 20 minutes. And we would really appreciate any questions you have. We will stop at 5 minutes of 10:20 to answer any questions. So feel free to put those in the Q&A as we go. Our first topic is around driving. 84% of the population in the United States drives, and car accidents are one of the leading causes of death. Dr. Odell, how can optometry play a role in reducing driving accidents?
Well, this kind of gets back to what you were talking about, just about the need of medical optometry and how, with the decline of ophthalmologists and the incline of patient counts, that we're going to really see how optometry is going to help with a big public health problem, which is the aging population. When you look at those numbers, 84% of the population drives, you kind of think, well, what percent of that is over the age of 65, where a lot of common ocular diseases that could limit vision exist? And that number is also on the rise. I recently saw some news reports that were talking about if we were at about 14% of the overall population in our country in 2001, we're increased that to about 21% now in the driving population over 65. And unfortunately, a lot of fatal crashes happen in that age group too. And that's also on the rise at about 19% in that 65 or older. So for me, driving is always difficult because independence and driving go hand in hand. And in our elderly population, the last thing we want to do is take independence. But I have relied very heavily on Esterman visual field testing to kind of be the bad guy when I don't want to be. So this test is unique in that it's binocular vision testing, providing up to 130 degrees. A lot of states are looking for 120 degrees continuous fields. But when I have patients that are selected for vision exams, or I know they've suffered a stroke or other, medical events that I'm worried about peripheral vision and their driving safety, this is my go-to test for me to know if they're legal. And obviously, we all have to know what our state guidelines are and how to report. But I think, first of all, just knowing and showing a patient this printout is so helpful for them to understand. My conversation goes like, Mrs. Jones, I know you want to be driving, but the last thing you want to do is not see somebody that's running across the street because your, peripheral vision's impaired, and no one ever wants to be the reason to harm another. And usually that will get them to stop and think, look at the field and say, you know what, you're right.
Yep. Thank you for that insight. Appreciate it. I know you do a lot of referring to oculoplastics. What testing do you do in your office ahead of that?
Well, oculoplastics is definitely an exciting area. It spans the gamut, if you will, from cosmetic things to eye disease. And it's been exciting to see new technologies and treatments come into the space of thyroid eye disease, where for years we really were very guarded on what we were doing with these patients because orbital decompression did not sound very attractive for anybody. But now with the with new medications like Tepezza, we're seeing dramatic improvement. And what I'm finding is my oculoplastics really appreciate having visual field testing ahead of my referral. You can actually see this talked about in a lot of optometry journals recently. Actually, Optometry Times and a colleague and friend, Dr. Brujic, spent some time talking through blepharoptosis in clinical practice. So if I'm thinking about blepharoptosis or I'm thinking about dermatochalasis, I want to know what degree or what impairment am I dealing with the superior field of vision. And that's where visual field testing is essential, right? We can test in the patient's natural state, and we can repeat our superior testing when we tape or hold the lids, so that we can simulate what a surgical procedure would look like.
I
I
see.
think in the case of thyroid eye disease, also, the visual field gives me a second. First, it's helping me see about lid positioning if that's a problem, but it
Mm,
also tells me what the status of the optic nerve is, because ultimately that is our, biggest concern is as the proptosis is advancing, are we having any problems to the optic nerve function?
Great. That was super insightful. Thank you for sharing that. Our next topic is, could you please discuss the difference in utilization between a glaucoma suspect versus a diagnosed patient?
Well, glaucoma, I think that a lot of my peers and, the eye care community is very, very comfortable with visual field testing as it pertains to glaucoma management in disease and also our glaucoma suspects. It's our function test, right? We don't know what to say about how our patient's performing really without a visual field test. Even though OCT is super important for our structural changes, we want to see what the visual status of our patients are. I look at visual field testing two different ways. I know I have access to a broader field in a 24-2
Mhm.
format, and then I have also a more detailed view of the central field, which is where we are really starting to see, especially early disease manifest when you're looking at retinal ganglion cell loss. We're seeing that happen in the macular area before the level of the optic nerve. So having a 10-2
Mm,
is really, really important for me in early disease. So for glaucoma suspects, I probably would, on average, do my visual field 24-2 annually and kind of let my OCT technology guide if I need to do it more frequently,
sure.
or if their risk factors might be that I would be more concerned. But I think annually is very reasonable for a suspect. In
Mm,
a treated patient, it's a little bit different for me. If I'm a newly treated patient and I want this report that you have on this slide,
mhm.
um, I need to do, a few fields, usually it's 3 to 5, in order to get the test to start giving me this predictor, this progression analysis. So I usually am a little bit more aggressive in my new starts or newly diagnosed patients in gathering up that data on probably a 3 or 6 month interval. And then depending on, again, the severity of disease, I will alternate at times that 24-2 with the 10-2. If
Okay.
I see 1 or 2 points in my center area
Yep,
fixation of a 24-2, I want to have that 10-2 to see how broad is that defect.
I see. Thank you for explaining when you'd use each type of exam. That was very insightful. Um, the next topic is, there's a lot of systemic diseases that patients are put on Plaquenil for. How common is this in your practice, and how do you figure out the protocol for these patients?
Well, Plaquenil is definitely a medication that is used very commonly for autoimmune type diseases and inflammatory processes. So I see it in my patients that have Sjogren's disease. I see it in patients with rheumatoid arthritis. I see it in patients with lupus. I mean, the list goes on and on. Um, what I think has been interesting to see over at my career is this medication went from one that we didn't have that much concern around to now patients are using it for 10 and 20 years. And guess what? That toxicity effect is a concern. Rheumatologists know about this, primary care providers know about it. So we actually have this great network of referrals coming from them. And so typically, depending on, like, usually a patient is to get visual field testing. I usually do color vision testing, and I get a baseline macular scan prior to them being started on Plaquenil. And then usually annually thereafter until they hit this magic number, which typically comes between 5 and 7 years of using the medication. It's actually a dose dependent type. So it has to do with the patient's weight and also their dose. And when are they going to get this cumulative effect that we really have concerns about toxicity? Once I hit that, I'm usually starting to do my testing on 6 month intervals.
Okay.
And that's because the vision loss that's seen in plaquenil toxicity really isn't reversible when the medication stops. So you want to be as proactive as you can in looking for that.
Awesome. Thank you for walking us through. Um, Different topic. So, as we know, diabetes is very prevalent and has been increasing over the years. And there's a growing number of patients with macular degeneration. What role do visual field tests play with these patients?
So I think that we're going to see. So if you look at this slide and you think about where diabetes and macular degeneration both have the risk of affecting, it's this central vision. So macular edema related to diabetes, or um, wet AMD, or geographic atrophy, all affect that foveal tissue, the macular region. So this disrupts your patient's central vision. When I'm looking at your acuity on an eye chart, you can easily see how if I put an eye chart up where the dog is missing, and the patient might see the first two letters on the line, miss the middle, see the last one. So you would still be able to chart that patient, say 20/50. We'll just use that as a metric, but it's not really a true 20/50. And if I don't have another functionality test, I might not realize where my patient's visual gap is. So I really think that we're going to see an uptick in the ability to use 10-2 testing, especially as it becomes easier in clinic. It's not taking up the same space in my clinic. I can do it in the exam room. It's better for, my patient's overall experience to increase my use of a 10-2 in patients with macular disease to better understand the functionality of that central field of vision.
Thank you. Thank you. And this is our last topic, and then we'll take questions. Migraines are a common issue. What type of workup would you recommend for this type of patient?
So migraines are I feel like, even some of the early data around, medications for helping presbyopia, it really pulled out like 15% of the population just had headaches chronically. I was surprised by that. And that was just like a daily log. Like, do you have a headache today? Migraines have a lot of visual implications. Sometimes patients will get um, auras, they'll get, flashes of light. They sometimes will even present with a hemianopsia. They completely have a peripheral vision loss. The good news about migraines being this vascular event is as the vascular stress improves and the blood flow normalizes, the visual system recovers. But it brings a lot of patients to me, honestly, as an emergency visit, especially that first time. And they always think, a majority of them all, think that they're having a stroke. They don't know about what that is, but they just think that that must be what it is. So being able to do testing, and usually the event's already over once I see a patient with a visual migraine. So my protocol has been 30-2 testing, because remember, when I'm looking for neurological disease, and really the visual field is the tool that helps us understand how the visual pathway is processing vision. You want the broadest scan you can get. So 30-2 is where you want to be.
Mhm.
But then color vision helps me assess nerve function and even macular function for that matter. But what I like about what virtual field has is the pupillometry also, because sometimes migraines can cause a spontaneous anisocoria with a pupil dilation. And I want to make sure that I'm documenting pupil size for these patients. Why? Because headaches can also be a warning sign of some bigger concerning problems for patients, whether it's a tumor, whether it's an aneurysm. And I want to make sure that those patients, especially, I have really, really good baseline data so that I know that how to monitor them for future events. Or unfortunately, you can have two things in the same person.
Great, great, awesome. Um, Thank you for that. We have a few questions, and we'll try to get to as many as possible. If we don't get to your question, we will be able to send you a response after. So the first is, how do you engage and educate patients about the significance of visual field tests? That's a really, really fascinating question. So how
Yeah,
do you
I think that's actually a great question. And I think that so an easy answer is education, right? So I educate the patient as to what I'm doing. So for example, if I have a patient that's presenting emergently for something like I was just discussing with a migraine event, let's say, I'll say this is my first step in knowing if I have to do more testing. This test provides me, sometimes I'll even say the visual field to me is kind of like my first step in MRI imaging. It helps me better understand how your eye and brain are processing things. Then if I look at things like chronic disease where I'm doing a visual field, my education to the patient is more around, this test helps me provide you with ideas around, is your disease state stable? What's your risk for progression? We know that everyone is fearing loss of vision, right? It's the sense that nobody wants to live without. It creates a lot of angst and anxiety in our patients. And by using the visual field as this metric and talking through it with your patients, you can really help them, get rid of some of the anxiety, build trust in you as their provider, and really just kind of own their disease. I feel like a lot of the fears go from them not understanding, the efforts. In glaucoma, for example, if I know that I take my medication or I have a procedure done on my eye, what's the outcome of that? Am I doing a good job? It's a great metric for patients to really see how they're doing from a disease management standpoint.
Thank you. The next question is also very interesting. How do you collaborate with other healthcare professionals, like a primary care physician or a neurologist, to ensure a holistic approach? Good one.
Well, I feel like another great question. So I love these. So communication and open lines of communication is the only way for us to manage patients that are, complex in nature. And so sometimes that means that I, have time set aside in my clinic day or, my lunch break or at the end of the day where I'm making phone calls. So I not only document, anytime I document and send a letter to these providers, I actually always include my testing. So I'll include my visual field test. And remember, my documentation has my summary of what that is interpreted to. So they don't have to understand the test to know what it means. And usually my call out in my letter is a short summary as to what they're looking at, what my concerns are. But then those are patients that I definitely pick up the phone also and get on the phone with the provider. And that really builds the provider's trust in what a medical optometrist is capable of doing and that they are able to manage these patients.
Cool. Thanks for that. Again, if we didn't get to your question, we will respond to you directly via email right after this webinar. As a aside, Virtual Field, who's hosting this webinar, we offer 12 exams that you can bill to 4 CPT codes. If you're not already a customer, I do see some customers on. Thank you so much for joining. If you're not already a customer, we would be happy to share more information on what we offer and how we can help streamline workflow and conduct these visual field exams and more. And thank you everybody for these 20 minutes. You're so happy that you gave us this time, and we hope that this was educational and informative. Very grateful to have you on. Thanks so much, Dr. Odell, for your time. Great insights. We appreciate it.
Oh, thanks so much for having me.